हाँ। Hello everyone. Good morning everyone. A very warm welcome to the respected guests and all the incredible audience. I feel privileged to open this event and stand here where many accomplished people who I admire and looked up to once stood. Jinsar. Jinsar Jabalpur Institute of Nursing Science and Research was established in the year 2001 as part of Hitkani Sabha and going and where to impart value-based education. Jinsar is a pioneer institution imparting quality nursing education and training in Jabalpur in Madhya Pradesh. It is approved by Indian Nursing Council, New Delhi, Department of Medical Education, Government
One such mode of continuous learning is faculty development program. The faculty development program intends to facilitate upgradation of knowledge, skills, and to cover areas such as new policies, new concepts, methods and techniques, theory and skill development, and upgradation of competencies related to teaching, professional practices, communication skills, management skills, and other relevant issues to keep pace with the changing scenario in nursing education. It will not only promote professional practices relevant to nursing education, but also motivate the faculties to achieve a competitive training and learning environment, thus channelizing development concerning to academic qualification and personal matters. For this year's session, Jinsar has opted for one such topic of relevance for nursing practice and education, that is OSCE, Objective Structured Clinical Examination. An objective structured clinical examination, it is a modern type of examination often used in health sciences. It is a hands-on real-world approach that keeps the examinees engaged, allows them to understand the key factors that drive the medical decision-making process, challenges the professional to be innovative, and reveals their errors in case finding, and provides an open space for improved decision making based on evidence-based practice for real-world responsibilities. It is one of the reliable, valid, and objective method of assessment for testing skills like communication, history taking, clinical examination skills, and procedural skills. It has become a widely used tool to teach, provide feedback on, and evaluate clinical skills. Therefore, a substantial knowledge, understanding, and experience is required for the successful conduction of OSCE. Hence, the faculty need to update and reorient themselves with this mode of clinical assessment to meet the rapidly changing professional and scientific needs of the stakeholders. This program focuses on teaching the concepts of objective structured clinical examination. In addition to theoretical concepts, different practical techniques will also be discussed. Now, the objectives of the FDP are to glance up an overview on OSCE, develop skills in designing OSCE, acquire knowledge and skill in marking and scoring of OSCE, core and master practice guidelines of OSCE, update the participants with the applicability of OSCE in nursing, develop an understanding of the OSCE scenarios, comprehend the benefits of OSCE over traditional clinical evaluation. Now, to achieve these objectives, our eminent speaker, Dr. Judy Arulapan ma'am, will share her expertise under the following topics: overview of OSCE, designing of OSCE, marking and scoring of OSCE, practice guidelines and applicability in nursing, developing OSCE scenarios, benefits of OSCE over traditional clinical evaluation. So this was the briefing of the faculty development program. I once again heartily welcome all the delegates and hope this program is going to be a great learning experience for all of us. Thank you.
Thank you, Sarika. Welcome the challenges, look for the opportunities in every situation to learn and grow in wisdom. It's my pleasure to introduce our resource person, Dr. Judy Arulapan Madam. Madam presently working as an assistant professor in Department of Maternal and Child Health, College of Nursing, Sultan Qaboos University, Al Khawd, Muscat, Sultanate of Oman. She completed her BSc Nursing from Sri Ramakrishna Institute of Paramedical Sciences, Coimbatore in April 1996, India. She completed her MSc Nursing from Sabita College of Nursing, Chennai, India in September 2000 in Child Health Nursing Specialty. She completed her PhD in Nursing from the Tamil Nadu, Dr. MGR Medical University, Chennai, India in October 2005. Date of award of degree January 2007. She also did Doctor of Nursing Science from Università Popolare degli Studi di Milano, Milan, Italy in September 2014 on adolescent epilepsy. She also did additional qualification certificates in CGFNS from the Commission of Graduates of Foreign Nursing School, USA, organization in June 2006. Oman Pometric Examination from OMSB Oman organization in November 2017. IELTS Academic from British Council in August 2018. IELTS General from British Council in February 2019. Madam also worked as a clinical instructor from Sabita College of Nursing, Chennai, India from 1996 to 1998 She worked as a lecturer from Savita College of Nursing, Chennai, India in October 2000 to December 2000. She worked as an assistant professor in Apollo College of Nursing, Chennai, India from January 2001 to September 2005. She worked as a principal in Maitri College of Nursing, Shimoga, India from October 2005 to April 2007. She worked as a principal in Bell RS College of Nursing, Chennai, India from May 2007 to August 2009. She worked as a principal in MMM College of Nursing, Chennai, India 2009 to 2013. She worked as a dean in SRM College of Nursing, SRM University, India from July 2013 to July 2015. Now she is working as an assistant professor in College of Nursing, Sultan Qaboos University, Sultanate of Oman from 1st September 2015. She also got Best Teacher Award in Apollo College of Nursing, Chennai, India in 2005. She also got Best Teacher Award from the TN Dr. MGR Medical University, Chennai, India 2021. Lifetime Achievement Doctorate Award from Sri Ramakrishnan Institute of Paramedical Sciences, Coimbatore, India in 2009. The Rashtriya Vidya Saraswati Puraskar from International Institute of Education and Management, New Delhi in 2006. Outstanding Scientist in Child Health Nursing from Venus International Foundation in 2018. Scientific and Research Excellence Award from VC of Sultanate Qaboos University in 2019. Best Reviewer Award 2021 from International Journal of Nutrition, Pharmacology, Neurological Diseases, India. Best Researcher Award 2021 from Sultan Qaboos University. Research Day 2015 Book Publication Award from Honorable Chancellor of SRM University, India. Excellence in Nursing Research Award 2015 from SRM College of Nursing, Tamil Nadu, India. She jointly developed nursing clinical assessment tool to evaluate the clinical performance of undergraduate nursing student in College of Nursing from Sultan Qaboos University. She also developed instrument to evaluate the OSCE station in advanced clinical nursing exit examination, which is considered as the program outcomes of the college. She also worked for introducing OSCE in exit course in College of Nursing in 2016. She also introducing OSCE in Child Health Nursing clinical course in summer 2017 in Oman. She also worked as an instructor and coordinator in 9 BSc Nursing and 2 MSc Nursing program from 2016 to 2022 with course title. She also did course teaching a survey from 2015 to 2019. Total number of students were 324. She also nominated for Best Teacher Award in 2019 from NCH Department College of Nursing in Sultanate Qaboos University. She also received a commendation letter for exceptional performance in teaching in 2016 from Assistant Dean for Clinical Affairs, College of Nursing, Sultan Qaboos University. She also participated actively in developing instruction materials such as manuals, guides, lab workbooks, audiovisual media, textbooks, software, e-learning resources, intelligent tutoring system protocols. She also participated in curriculum development in different universities. She also actively participated in citation in journal from total number of citation 515 in 16 journals. She also actively participated in oral and poster presentation in Sultan Qaboos University. She also worked as an internal and external examiner in PhD and MSc thesis. The words are very less to express about Madam publication works. We feel very proud for this eminent personality with us. Madam, your presence makes us feel very happy. We welcome you, Madam, as a speaker on today's online faculty development program on behalf of our entire Jinsar family. Now I welcome you, Madam, for starting your topics.
A very good morning, everybody. Am I audible to everyone?
Yeah, yes, ma'am.
Okay, thank you. Thank you so much. Maybe if everybody could mute the mic, then I will be able to talk without any interruption. Maybe at the end of my presentation, if you have any doubts, I'll be happy to clarify your doubts. Please make a note of your doubts so that I will be able to clarify at the end of my presentation. So with this, I would like to start. I would like to share my screen now. Can you ask the person to close, because I think somebody else have kept the screen on. Is my screen visible?
No, ma'am, not yet.
Now?
No, ma'am. No, ma'am.
It shows that I'm able to share the screen now.
Yes, ma'am. Yes. Now it is visible, ma'am.
Okay. Thank you very much. So I am Dr. Judy Arlappan, as introduced by Dr. Shurbi. Thank you very much for such a vast introduction. I feel really humbled and honored to receive your words of appreciation and the welcome note. Thank you very much, Ms. Dr. Shurbi, for introducing me to this online forum. I am Dr. Judy Arlappan. I am working as assistant professor in the Department of Maternal and Child Health, College of Nursing, Sultan Qaboos University, Oman. This is my mail ID and my contact number. And this is our university standardized patients for our procedures. However, marking is done by the teachers in our university. So coming to the traditional methods, we have many traditional methods, including short case and long cases during the clinical examination. The cases will be given with complex scenarios, and we will have viva voce examination. All these were done by traditional clinical examination. During this, it is lacking the structure and standardization. As I already mentioned, it is not standardized. Every student will not get equal chance of being examining the same patient. And poor inter-rater reliability, because each examiner may evaluate in a different way and not minimizing examiner bias. Definitely, there is a possibility for examiner bias. That is the reason we always invite one internal examiner and one external examiner, because internal examiner, we always assume that there may be a chance for examiner bias, but external examiner may be totally new to the situation. Therefore, though we do all this, traditional methods lacks structure and standardization. Therefore, OSCE with multiple standardized cases and scoring rubric is now widely used as a gold standard and universal format to assess the clinical competency of medical and nursing students. Across the world, if you see everywhere, OSCE is introduced. So OSCE with multiple standardized cases, because it has become a gold standard or universal format of assessing the clinical competency of medical nursing students and other healthcare students. So over the past decades, it has been proven to be valid and reliable tool. See, it is considered as because many research has been conducted and they have proved that OSCE is a valid and reliable method of assessing the cognitive, affective and psychomotor skills. And they are also believing that we are following a pyramid called as Miller's pyramid, which indicates a particular category shows how. So in OSCE, we are following that step of shows how. I will explain about Miller's pyramid in the next slide. So it has widely been adopted as the examination of clinical competence across the world, and it is practiced well in the undergraduate, postgraduate, and licensing exam. So you might wonder where this licensing exam may take place, because undergraduate, postgraduate exams across the world, everywhere it is followed. Same way in nowadays, many countries have introduced OSCE as a licensing exam before they are recruited. If you see UK, and then they have to pass the OSCE before getting into the job in UK. Whether they are entering into a teaching position or whether they are entering into a clinical position, they are supposed to pass the English examination as well as the OSCE examination before getting a job. So that is a practice nowadays. It is coming up with OSCE, because every country wanted to assess the clinical competencies, because earlier we used to be assessed only in the theoretical knowledge, because only we will be giving a NCLEX exam. So in that, only computer-based questions we will be answering. But if you see OSCE, definitely we wanted to, because nurses, we are basically skill-based professionals. So our skills are needed and our skills have to be examined by the recruiters. So they are assessing our skills, how we are competent in performing the skills, so that the patient care will be, we will be able to provide quality care without harming the patient safety. That is the reason we are nowadays licensing examination also OSCE is introduced. So though we have lots of positive points about OSCE, it is a complex, resource and time intensive assessment exercise. Really, it needs a lot of preparation. Without preparation, it is not easy to do a OSCE examination. But however, it is the best method of evaluation, I would say. Let us see the Miller's pyramid or pyramid of competence. Okay, so this is the pyramid of competence we follow in our OSCE. So if you see this Miller's pyramid, this is the Miller's pyramid. So it starts with MCQs at that's a nose level, then knows how, then again MCQs, essays like that, shows how, it is OSCE, does work-based assessment. I will explain further. So if you see on the lowest level of the pyramid is knowledge, okay? It is tested by written exams and traditional multiple choice questions. And if you come to the next test, we are trying to apply the knowledge which is assessed by essays, clinical problem solving exercises and extended MCQs. And the third tier of pyramid is representing the clinical skills competency, which is assessed by the standardized patient exercises, simulation and clinical exams. So that is OSCE. So finally, on the top of the pyramid is the clinical performance, which is assessed directly by observing the students in the real clinical setting. So for example, in our university, we follow this practice, because in the level 1, the Miller's pyramid we are following in our university also. If you see, when they come to the final level, they are examined in an exit OSCE, then they will be made to practice in the clinical, as well as they are given a clinical examination also at the end, so that we will be able to evaluate their skills before they go into the real clinical practice. So in our college, OSCE is practiced from the level 1 course, like say for example, fundamentals of nursing, health assessment, adult health, maternity nursing, child health nursing, mental health nursing, nursing administration, advanced clinical nursing. All these courses, we have OSCE practice. Almost every course has OSCE. So this Miller's model suggests that simulated practice is a very good practice which provide good approximation, whereas the students can we can understand how the students would behave in a real world clinical setting, so that before they go for the real world clinical testing, we are testing them through OSCE. So that is what I explained in this picture as well. So now let us see how this OSCE really originated, because just briefly to make you understand since how long it is here. It is introduced only in 1975. It is around 46 years old only. Okay. So however, though it is 46 years old, in our settings nowadays only we have started introducing this. Even in our university, I mentioned since 7 years we are using this OSCE in the exit examination. Before that, there was a clinical examination as a exit examination. However, nowadays, since 7 years after we test it, we started understanding the importance of this OSCE and we introduced it into our curriculum. So therefore, it was introduced by Harden et al. In 1975 in the medical school, because he understood lots of practical problems in the clinical examination, so that he understood that similar skills could not be assessed in the students, and there is no uniformity, there is no complexity, it is not reliable and valid. And in order to improve the quality of the clinical performance of the students, he introduced OSCE in the medical school. Then he also said that it's a timed examination where we have simulated patients and we can start doing history taking, physical examination, counseling, and patient management. And also it can be done for both undergraduate and postgraduate students. And in the Miller's pyramid, we are following OSCE in the shows how level of pyramid, as well as OSCE can be done in both formative and summative assessment. This is very important. I want you to understand, because formative assessment is done during the course, during the semester. Because during formative assessment, we can give feedback to the students and the students will know where they are lacking, what they are lacking. They can understand their area of improvement and they can improve their performance in this final examination. That is the reason formative OSCE is very important, and formative OSCE will be helpful in for the students to do better performance in the summative assessment. So summative OSCE is usually done in the end of courses or programs, and it really will be assessed against the set of objectives and learning outcomes. As I mentioned, in our university, we do both summative OSCE as well as formative OSCE, because we give feedback to the students during the course and we evaluate them at the end of the course as well. So both we are doing. In formative assessment, the feedback will be really helping the students to improve their progress. And especially we have a practice called as pass and fail practice. So before any clinical, say for example, the students will be going to the clinicals mainly from adult health nursing. So before they go to the clinicals in adult health nursing, they have to pass all the clinical skills related to adult health nursing in the laboratory. Everybody will be made to practice the skills in the laboratory, and they will be given the OSCE in the laboratory. And if the students pass the skills, then only they will be permitted to enter into the clinical. Till they are well versed in their prior skill, they will not be permitted to go to the clinical. So we keep a criteria called as pass and fail criteria. So in that pass and fail criteria, when the students are performing well according to the checklist without any without missing any critical elements, then the students will be permitted to enter into the clinical area. So therefore, this is the best strategy where we can really prepare the students with their hands-on skill before they go to the clinical practice. So in this, we can assess the psychomotor, cognitive, and affective skills in a simulated environment, and we can understand their performance. Okay, so now let us see how we can design OSCE. This is a very important step. We should know how we can design the OSCE. So for that, we should have an OSCE committee. For example, when we introduced this OSCE in our advanced clinical course, so our course team was developed or trained for this OSCE examination. So there should be a committee. There should be a committee exclusively available for this particular examination. For example, if the OSCE is going to be conducted in a maternity course, the maternity specialized faculty who are teaching that course should be forming a committee. If there is a pediatric team, the pediatric team should be trained to develop scenarios, everything, and that should be a committee. So based on the course objectives and the requirements, the committee should be formulated and the faculty should be trained. So in the faculty itself, there are two types of faculty. One group of faculty are called as facilitators, and other group of faculty are called as examiners. Facilitators are the one who will be helping in setting up the lab and coordinating the OSCE activity, preparing the OSCE schedule, everything. They are called as facilitators. Examiners are the one who will be examining the students objectively behind the screen. So they will not be exactly visible in front of the students because they will be sitting behind the screen, because the students should not have any test anxiety. That is the reason in our university, what we do, we make the examiners to sit behind a glass screen so that completely it will be visible to the examiners, and the students will not feel that there is examiners who are observing. The students will do the exam without any panicky situation, without feeling panicky. And we have to train the students. We have to give lots of practice sessions, and with that they should be getting lots of training. And we also should have a mock OSCE. Mock OSCE is like a pilot OSCE. Before going for the main OSCE, we have to do a mock OSCE with a different scenario, and we should see the students' performance, and we can give feedback to the students, so the students will be able to understand their areas of improvement. And we should be able to construct an exam blueprint, OSCE exam blueprint. So in that OSCE exam blueprint, we should be deciding how many stations we need, how many rest stations. Because what is a rest station? Because every student may not be able to progress to the next student. Say, for example, when the student is completing 3 stations, the student may be exhausted. So therefore, we will give us rest station where the students will break for 15 minutes. Then the next station will say, go on. However, when you are giving rest stations, we will make sure the students who did the procedure and students who did not do the procedure will not mix up. Why? Because if they are mixing up, they may share the scenario. Therefore, we should have a separate rest station for the students who already completed the stations. There should be a rest station students who are still doing the procedures. There should be a rest station who's for the students who did not start the exam itself. So therefore, 3 different rooms should be available as rest stations, so that the students will not mix with each other, or students will not share with each other. And we should decide the skills, time, check off, what is the follow-up station, everything we should decide. What is a follow-up station? For example, if you take in our college also we do that. For example, a first station will start with a similar patient scenario. The student will start the history taking. In the second station, the student will do a physical examination. For the same patient, the student will do a skill. So it will be a same patient scenario, but it will continue as different.
Madam, you are muted. Your voice is not audible. Judy, madam. Excuse me, ma'am. You are muted.
Ma'am, it is not audible, ma'am. It's not audible. Mic is off.
Since when? Since when?
Just now, ma'am.
Ma'am, third point ke baad, after the mock test.
After the mock test. Okay. I'm
Yes,
sorry, I
ma'am.
don't know.
Yes.
Now can you hear me?
Yes, ma'am.
Okay. So what we have to do is we have to train the students through practice sessions and mock OSCE. Say, for example, we should be giving practice sessions for the students, and after the practice session, we should conduct a mock OSCE. It will be similar like a real OSCE. However, that mock OSCE scenario will not be repeated in the real OSCE scenario, because the students are given a trial and they will be given feedback in the mock OSCE. And we should be constructing a blueprint. When we are constructing the blueprint, we should be deciding how many stations we need, how many rest stations we need, what type of skill we are going to give, time, check off, follow-up station. I want you to understand what is rest station. Say, for example, after 2 to 3 stations, the students may get exhausted. When the students are getting exhausted, the students may not be able to perform well in the next station. Therefore, there should be a rest station available after 2-3 stations. For example, we should have minimum 3 rest stations. Why? Because the students who have not started the OSCE station will be kept in separate room. The students who completed half of the station will be separated in, kept in another room. The students who have completed the stations will be kept in another room. Why? Because when we are keeping them together, they may share the scenario, because the scenario is going to be the same for the whole day. Therefore, we should be keeping 3 different test stations so that the students will not mix up with each other. And there is something called as follow-up station, because in follow-up station, there is a situation called as when we start a scenario in one station, the scenario will be the same, but the steps may be different. I may start with a patient with pneumonia. So I may be asking the student to do a history taking. Then when the student comes to the physical examination station, I may ask the student to do a physical examination, considering the pneumonia symptoms, everything. And when the student goes to the third station, I may ask the student to do a nebulization. But it will be a continuation to this previous scenario. So that is called as follow-up station. We should decide whether it is a follow-up station or independent station. Some station will be totally independent with each other. There will not be any connectivity, but it will be different skills which is not related to a particular scenario. Therefore, we should decide whether we are going to create an independent station or whether we are going to create a follow-up station. That is very important. And we should write the cases and probes. That is, scenario writing is very important, especially when we write the scenario. It should be that we should have good training. Why? Because the scenarios books are available for the scenario. Okay, scenarios books are available. However, the books, every time the scenarios may not be so realistic. Therefore, we should consider our clinical situation, our cultural background, and based on our culture and our clinical situation, we should be developing our own scenarios. So therefore, we should be having good expertise in preparing the scenarios. As well as we should be constructing the checklist for each case, because each station will have different situation. Therefore, the checklist should be different for each station. And we should be training and recruiting the standardized patient. This is very important, because the standardized patient is otherwise known as standardized patient, simulated patient, or real patients, or because this real patient, they are trained to consistently and accurately portray specific emotions, behaviors, and disease symptoms. Exactly, they should act like a real patient. All these training should be done by the for the standardized patient. Then we should be piloting the exam and revising it as needed, because before it is tested on the students, because we cannot play with the life of the students. Therefore, before testing it on the students, we have to pilot it in the lab, whether everything is working perfectly, whether all the equipments are available, whether everything is available in the laboratory, so that we have to pilot it and we have to revise if it is required before the actual exam. Then conduct the full-scale exam. Then we have to analyze the results. How did it go? And finally, we have to report the results. How many passed? How many failed? How many are safe? How many are unsafe to practice? All these we have to decide in this stage. So this is the way we have to prepare for the exam. Now let me say about the OSCE environment. OSCE environment, as I already mentioned, either it can be one station with one skill, or it can be many stations with a clinical skill as well as theoretical knowledge. And some stations will have a standardized patient. Sometimes some station will be unmanned. That means nobody will be there. Only the papers will be kept and the students have to write and move on. So therefore, it may be starting with the vital signs, or it may be doing a dressing change, or whatever it may be, depending upon the course requirement. If it is adult health nursing course, depending upon the course requirement, you can plan the station. So if it is a child health nursing, say for example, in child health nursing, we may have to have growth and development as one part of the assessment. However, it may be very difficult to have a child with real child in having a real child as a SP. However, we should have good mannequins in our laboratory, especially high fidelity mannequins should be available in our laboratory so that the students can do that. So in such a way, depending upon the level, we can create the OSCE environment and we can create the type of examination also, whether it can be a paper-based exam, or whether it is a verbal exam, or whether it is a staff station, or whether it is unmanned station or unstaffed station. We can decide, because I want you to understand, because I told you there will be some stations which is manned or staffed or with a standardized patient. That means manned means somebody will be there to voice over. In some station, only the paper and pencil will be kept. In some station, there will be verbal exercise asking questions. Say, for example, when you wanted to assess how the students are able to understand the equipments used in the operation theatre, you may keep a variety of equipments in the particular table, and the student may be asked to verbalize what is this particular instrument. So that way also we can keep. So depending upon the need, multiple stations can be created and their skills can be assessed. So therefore, the OSCE environment can be varying from one type to many types. It can be created with our innovation and creativity. So it can include scenarios, case studies, simulations, everything where the students can perform a specific skill and the students can interpret the information and the students can make clinical decisions and communicate with the patients, and even they can communicate with the family members, so that we can create any type of situation in the OSCE environment. So the stations, as the students are progressing from a lower level to higher level, the complexity of the stations will become high. For example, can we keep an adult CPR for a level 1 student? We cannot do it. Why? Because adult CPR cannot be performed by a level 1 student. Therefore, that can be kept only at the 4th level. So depending upon the level of the study, the complexity of the procedures can be kept in the station. So therefore, the real patients are frequently used in, say, for example, in College of Medicine, they use real patients if possible, and they will observe, however, real patients in the sense, really trained patients exactly mimicking the symptoms of a real patient. And in mostly in the nursing also, we have role players or standardized patients mostly we are using, or we can use the high fidelity mannequins, because high fidelity mannequins can cry, they can sweat, and they can show changes in the vital signs. All that is possible with high fidelity mannequins. Any type can be used. Therefore, the OSCEs are to assess the skills in isolation, or we can do it in a more holistic way. As I mentioned, the follow-up station, we can do more holistically, because the students will be having the same scenario and they will be moving around the same scenario with different types of skills. So that we can do isolation as well as we can do in comprehensively, and we can evaluate. And during this time, filming is very important, because recording is very important. What happens for the recording? Because the laboratory should have a recording facility. Why? Because we wanted to make sure that the students have done everything perfectly. If you have some queries, you can go back to the recording and check whether the student did this step, whether the student missed this step, so that we will not go wrong in evaluating the students. Therefore, this recording is very important to identify the areas where the students need to improve, and also it helps to resolve a query regarding a student's performance, and we can form a moderation. For this purpose, this filming or recording is very important. Therefore, in our university, we have this recording facility during the summative OSCE, because we wanted to get real feedback on the examination process. So in case if there is conflict between two examiners, and if the students say, no, we did it, and you are saying that we didn't do it, when the students argue with the examiners, we have the backup of recording session, so that we will go back to the recording session and tell the students, see, you did this mistake, so that we will be able to clarify the doubt with the students. That is how we do that. So this is very important step we follow in our university. Now coming to the student preparation. For example, now this is one station I put the picture, where we can keep a picture in the particular station, and we can ask the student to say, what is this picture say about? What is this particular symptom? Whether it is a symptom of goiter or whether it is something else. So we can really ask the student to interpret the finding by looking at the picture also. That also is possible in OSCE station. So therefore, if you see the student preparation, the student should be psychologically prepared, and the student should be familiar with the equipments, because how the equipment works. Because we had some challenges during our OSCE sessions. What happens when we have the OSCE session in the laboratory? Some equipments, some medicines, exact medicines we cannot keep in the laboratory. What we do, we print the paper like a medication, and we keep it on the bottle. The students always get confused between in the hospital the medication looks different, in the laboratory the medication looks different. So therefore, after facing this challenge, we really had requested the laboratory equipment preparing people to prepare simulated medication itself. That simulated medications are made readily available, which will be exactly looking like the hospital medicine. However, the inside, it may not be a true medicine, but the label exactly look like a hospital medicine, so that the students will not have confusion. So that therefore, the student should be familiar with the hospital equipments in the hospital, in the laboratory, and the student also should know which procedure or guidelines are to be used in the OSCE, and they should be familiar with the checklist and marking criteria, and they should be able to rehearse the skills in the laboratory, and they should know the timing of the OSCE, how many minutes for each station, that they should be knowing it. Then they should be developing the skills, and they should revise the underpinning theory of the skills. That is very important, because if the students are not learning the theory related to the skill, they may not be able to perform the skill appropriately. Therefore, they should revise the theory of the skill before they come for the practice. And they should use the feedback from mock and formative OSCE, because whatever feedback they received from the mock and formative OSCE, they should be able to integrate that when they are doing the final OSCE. They should not make such mistake when they come for the final OSCE. And they should be using the available resources such as guided study, quizzes, videos, everything, so that they will be able to follow the steps exactly. In our university, we have prepared skill videos. The skills, whatever we perform in all the courses, we have already recorded, and it is done by the teachers, and it is recorded and uploaded in our Moodle page, so that the students can view that prepared videos anytime before they come for the practice, so that they will be able to understand this is the step I have to follow. And we should the students should be in uniform, because they should understand this is exactly mimicking the hospital setting. They should be in uniform when they come to the laboratory, and they should be confirming the day, time, venue, and everything. They should be agreeing to that. And they also should be able to practice the answering questions verbally, how they have to answer. They should rehearse it. And coming to the role player preparation, we call as standardized patient preparation. They should have clear guidelines, and they should know the role and how to interact with the student. For example, the standardized patient should be prepared in such a way that the standardized patient do not talk too much to the student. What will happen, when the standardized patient talk too much, the student may get clue. What is the patient trying to say? So in order to avoid clue, the standardized patient should be trained in a way that he is limiting the talk. Unnecessarily, he should not talk, because unnecessarily, if he is talking, he may mislead the communication with the student, and the student may get confused, or student may get the clue. Therefore, SP should be given as SP dialogue sheet. We call it as SP dialogue sheet. I will show in the next slides. And in the SP dialogue sheet, when we show that the standardized patient should be trained to talk only that. He should not be talking extra. Okay. As well as the assessor. The assessor is the teacher or evaluator. The person should be given a global rating scale or a checklist to assess the particular station. And the student must be made to aware that the student should not ask too many questions to SP. Student also should be made to aware of that. And the assessor also should be understanding about the marking criteria and guidelines, because it is very important. Sometimes some people may be coming for the first time to assess the OSCE station. So they may not know how to do that. So that they should be having a mock session before the actual OSCE practice, so that they will not do mistake when they are coming for the OSCE, because OSCE is the examination, because it is connected to the students' marks and grades. Therefore, there should not be any mistakes in terms of SP. There should not be any mistake from the part of the evaluator, or there should not be any mistake from the part of the student. That is the reason the preparation for the student, preparation for the assessor, and preparation for the role player or SP is very important. Now, there are two types of things. As I already mentioned, I am again telling you, practical things can be assessed in some station. Questions can be assessed in some station. As I mentioned, scenarios can be kept in some stations, and that can be assessed. Some station skills can be kept. Say, for example, when they are standing in the OSCE station, they should not be seeing each other, because in order to maintain the confidentiality, we make sure that the students are not meeting each other, and they will be standing in their respective station in front of their respective station, so that they don't come in communication with each other. This we should be very careful. And coming to the OSCE format, each station will give a signal when to enter and when to leave. There will be a bell ringing, so that the student will know this is the time I'm supposed to enter. When the next bell rings, the student should know that this is the time I'm supposed to leave the station. And each OSCE station is timed. Every station will have exact timing. Immediately, as soon as the bell rings, the student have to move out. And there will be many candidates, so that they should be rotated with all the station. That is the reason we prepare something called as OSCE schedule. So OSCE schedule will be prepared in such a way that each student will have a timing. So that exact timing should be followed with the OSCE schedule, so that the time will go on exactly without any interruption. Also, we should be keeping them in the resting rooms, as I already mentioned, to ensure that there is no contact between the students. So as each station is unique, the equipment, setting, standardized patient, everybody will be varying from each station to another station. And the students also should understand the station instructions are available in each station for reference, as well as similarly, all the available materials like growth chart, lab results, and other information should be made available in the station. Exactly, it should be like a hospital. Don't think that it is a lab and anything can be done. No, it should be exactly mimicking like a hospital setting, so that all the available information should be available. However, in some station, what we do, we keep some information away. For example, there may be a clinical situation where the student should understand that the patient blood sugar is very high. Maybe it is 250 or 300 that particular point of time when the blood glucose is taken. The student has to understand what I should do now, the sliding scale, I should see the sliding scale. After seeing the sliding scale only, I can administer insulin, and or I should be calling a doctor. Which doctor I should call? And the student should be looking for the information in the lab, whether the doctor's number is kept over there, whether there is a telephone which is kept over there, so that the student should understand, okay, this particular information is available, so that I can call the doctor and find out the patient's blood sugar is very high. So what can I do? So they should be using the SBAR communication strategy, and they should be asking the doctor, this is the situation. What is your recommendation? The doctor might say, please see the sliding scale and you can administer insulin injection. The student should be able to see the sliding scale, which should be available in the lab. However, we can create some tricky situation where some information will be missing and the student has to ask for it, because student should know the situation. I should be looking for a sliding scale. Wherever sliding scale is not available, the student will ask the examiner, the teacher. So the sliding scale is not available. Can you please provide a sliding scale so that I will be able to follow the doctor's advice? So that way, in order to stimulate the critical thinking ability also, we can remove some information so that the students can understand that it is needed in the station to perform the skill. That way, we can create the OSCE format. Student feedback is very, very important in case of OSCE. Why? Because for the students who are performing well, as well as for the students who are not performing well, feedback is very important. Why? Because the students who are successful, they will try to improve their proficiency. And at the same time, yes? Are you able to hear me?
Yes, ma'am.
Okay. So the students who are successful, they will be able to improve their proficiency. At the same time, the students who are unsuccessful, they will be able to identify the areas of improvement. For that purpose only, we follow something called as reflection. Okay. The students should be able to reflect on their performance. For this reflection, we follow a cycle called as Gibbs reflexive cycle. If you see this Gibbs reflexive cycle, the students have to describe what happened in the particular station. They should be able to explain their feelings, how they were feeling at that particular point of time. And they should be able to say what is good and what is bad about their experience. And they should be able to analyze what else could be done to change the situation. And they should be able to conclude what they could have done, because they would have missed an important point, and they should be able to understand what they have missed. And finally, they should be able to take action plan. If it comes again, what am I going to do? So this reflection cycle, we make the students to follow this Gibbs reflection cycle at the end of OSCE, so that the students will understand their mistake by reflecting on their own performance. That is called as reflection cycle. Please, if anybody is not following this, please follow this, because this is a very good reflection cycle where the students will be able to understand where they stand. So this is the practice we follow in our university as well. Now coming to the marking and scoring of OSCE. This is a very important step I want you to understand, because the marking, you may be wondering whether only by a checklist we can mark OSCE, or whether there is any other criteria available to mark OSCE. There are 2-3 methods available to mark OSCE. First one is checklist is frequently used because it is objectivity and reliability of the assessment can be done. Though there are different evaluators, different station, when we have checklist corresponding to the particular station, with the different evaluators, we can say, for example, the same station may be running in 2 places. Okay. So there may be 2 teams of examiners. 2 teams of examiners will be evaluating them objectively with reliability. Why? Because they are given the checklist. When they are given the checklist, they will exactly follow whatever the steps the students have followed. Even in the station, the evaluation may be correct. Even in the next station, the evaluation may be correct, because they have a pre-tested checklist, which is already listed with yes, 1, 2, 3, 4, 5. And yes, no, so that the examiners will not miss out any point. Similarly, they can write whether it is achieved or not, yes or no. Okay. In some other type of evaluation, the complete session will be evaluated for the professional behavior, communication, concern, hand washing, temperature, pulse, respiratory rate, blood pressure, skill. Everything will be evaluated in a comprehensive evaluation. Say, for example, in some skill part, they will keep a checklist either to achieve or not achieve. In some other station, they will assess all these aspects. So they will be comprehensively assessing also. That is also possible. There is another thing called as global rating scale. Okay, this global rating scale, it can be a combination of both checklist as well as with the criteria. So everything here in the global rating scale, we can assess the overall quality of the student's performance. For example, in this global rating scale, we may have category like excellent, satisfactory, borderline, pass, fail. All these categories may be available, so that the examiners can choose which category the student is falling, because for each category the descriptions are given, so that examiners can choose which category they can choose for the student. Similarly, there are Likert scales having pass, borderline, fail also. And nowadays there is an advancement like online management information system, OMIS we call it as. So it's an electronic. So as soon as the student does the exam, immediately on the online itself they will enter the data, the results. Immediately they can enter the data online, and it will be submitted to the examination committee. So all these, for this online, for this exam evaluation, the assessor or the evaluator should have good understanding about the assessment and marking tool. I want you to show these two pictures, two evaluation criteria, for you to understand the difference between a global rating scale as well as a checklist. It is for the same skill, okay, skin suturing. If you see, the steps are given 1, 2, 3, 4, 1 to 12 steps are given. So yes, no. So the examiner will evaluate yes or no. If the student does it, yes. If the student do not do it, no. And at the same time, this is checklist. If you see the left side, you see the global rating scale, because here we have rating clearly below expectations, acceptable performance, performs above expectation. What is the meaning of clearly below expectation? What is the meaning of acceptable performance? What is the meaning of performs above expectation? So the score is ranging from 1 to 5. So based on the performance of the students, the examiner may give 1, 2, 3, 4, 5, depending upon the performance. But in this case, checklist, it is not very comprehensive. See, you can write either yes or no. There is more probability for the students to miss many marks in this checklist. However, in the global rating scale, there is a possibility or a flexibility for the students to have little bit of adjusted scores. That is the reason now in our university, we follow the global rating scale for evaluating the students' performance. So now I am saying some practice guidelines for each one of us, so that we will go properly with the practice guidelines in performing OSCE. Coming to the students should be practicing as many as times possible with the instructor in the lab. And they should be also paying attention to the verbal and written instructions, and they should clarify the queries before the exam. And they also should check the equipment's availability in the laboratory, and they should be staying calm and focused. They should not be stressful, okay? And also, there is a possibility in the OSCE station that students can correct themselves. For example, when they do OSCE, imagine that we are giving a clinical situation of medication preparation. So during the medication preparation, we are seeing the student taking a wrong dose. Instead of 0.4, the student may take 4 mg. Okay, so we are observing that the student is taking wrong dose. However, before going near to the patient, the student is realizing, oh, I think I did some mistake. So let me go back and correct myself. When the student herself or himself is realizing that the student has done the mistake, we always can give a chance to correct the student. However, we should not give any prompting. That means, as examiners, we should never tell, are you doing correctly? Hope you are doing wrong. You should never give any clue to the students, because it is an examination. It's a structured examination. Therefore, we should never give any clue to the students. Instead, if the student herself or himself is correcting that she is doing a mistake, we can give that opportunity for the student to realize that the student is doing mistake. But we should never give any comment in that situation also, because we are just observing the students. That's it. No communication between the examiner and the students in this structured examination format. And also, the student should have an eye on the time, and they should be able to communicate with the patients and the caregiver. And the student should make sure that the student has completed all the steps, and they should be also maintaining a confidentiality. Why? Because they should sign in the confidentiality pledge that they will not share the information to their friends at any point. So that is the reason I told that camera should be kept on, that it should be recorded. Any point, the complete simulation lab, if you see our institution, all the full lab will be recorded with the cameras. Everywhere in the walkway or inside the station, everywhere there will be cameras. So we cannot have any form of cheating in this OSCE examination. Coming to the examiners, I already told you that the examiner should understand the examination format, and they should know the requirements and scoring guidelines, as well as they should know the they should standardize the scoring format. That is very important, because standardizing the scoring format is very important, because before the exam, they should go to the lab, they should pre-test the scenario, and they should see whether inter-rater and intra-rater variances are existing. Because when there is some variances existing in the exam, definitely we may be taking we may not be able to take appropriate decisions in the students to pass or fail. That is the reason we have to test whether everything is perfectly arranged in the checklist or in the global rating scale, so that none of the points will be missed and the students will not be affected in any way. As well as the untrained examiners, they may erode the credibility of the examination. Therefore, we should be calling only trained examiners who in OSCE should be invited as the examiner. The untrained examiners are very dangerous because they, without knowing the process, they may fail the students. Ultimately, it will be a loss for the students, and loss for the resources also. And coming to this SPs, as I already mentioned, SPs training is very important, because I'm repeatedly telling, because this is very important part. Consistency and accuracy of very important, because if the SP is trying to speak the same way, he should be speaking the same way with all the students. He should not be speaking differently with one student, and he should not be speaking indifferently with another student. He should be speaking same way with everybody. And inadequately trained OSCE SPs, definitely there will be error, possibility for lots of error in the OSCE station. So therefore, it may result in lower reliability of the examination process. That is the reason I told SP dialogue or script for the SP should be prepared, and it should be explained, and they should be rehearsed. All that has to be done. For example, you may think who can be called as SP. For example, we can invite lay people, actors, actress, nurses, medical students, house officers. They can be called as SP. However, they should be able to speak the local language. For example, if the exam is going to be conducted in English, whoever is called as SP should be able to communicate in English. Otherwise, the examiner may be from another country. So the examiner may not be able to understand the language. Therefore, the person, the student who is doing the skill, the SP who is there in the station, as well as the examiner who is there in the station, should be able to communicate in the same language. Therefore, each of them will understand each other. Therefore, they should be trained to speak well, and they should be paid SPs, because if you pay only, they will do their job perfectly. So therefore, in our university, we call them, we pay for 1 hour, we pay 1,000 rupees, that is 5 real we pay for them, so that they will be trained perfectly to talk during the examination. And we can maintain the consistency and accuracy in the examination. Similarly, they should be maintaining security and confidentiality of the script. They should not be leaking the information to the students before they do the exam. So security and confidentiality of the script should be maintained by the standardized patients. And the standardized patient should be intelligent, flexible, quick thinking, and they should be reliable. Okay. And also we also should maintain the mannequins and models in proper way, so that along with the SP, the mannequins also will be there sometimes in the station, so that the mannequins also should be well prepared, so that say for example, I would like to say about a situation. Imagine that the students wish to conduct a delivery. So there may be a SP who may be lying like a human, but in the abdomen area there may be a simulator, and the student will be performing in the simulator. So that there is an SP to talk. At the same time, there is another model, a simulation model, with which the student will be conducting a delivery. So like that, we should have combined situation also. The SP also will be there, and mannequin also will be there. So in that situation, the mannequins also should be kept in a functioning state. And now I just wanted to show a practical tip what we are doing in our university, so that it will be very useful for all of you. I'm just giving practical tips, and I'm going to show the rubrics and the sheets, whatever we use in our university. So for this, as I already mentioned, there should be some preparation and planning, pre-briefing. So preparation and planning, I already explained what are the preparation we should do. I clearly explained to you. And pre-briefing, we should have theory lectures for the students, and the students should have basic idea about what they are going to do in the lab, so that that is called as pre-briefing. And the examination day briefing. So during this examination day briefing, the students should be oriented to the OSCE procedures, and they also should be oriented to the lab, and they should be oriented to the type of exam, everything. And on the day of examination, we can decide about the number of stations, number of minutes for each station, how many minutes to read, how many minutes to perform. All that has to be given during the examination day. And finally, debriefing. This is the time they will be giving a feedback. Okay. So during the debriefing, the students will be getting feedback from the examiners, and they will be able to correct themselves. This is the flow chart we follow usually. So now in our college, what we do, it is my own reflection just to explain you. So we always give a OSCE preparation prep sheet, that is called as preparation sheet. We give a OSCE prep sheet in the beginning of the course. Okay, so depending upon the course requirement, in the beginning of the course itself, we will say these are the items you need to prepare in the OSCE prep sheet. And we give OSCE practice sessions for the students every week. there will be a lab day, and the particular lab day, the students have to come to the lab to practice OSCE along with the teachers. And we give sample OSCE scenarios to students for practice. 2 sample scenarios we give them, and they practice with that. And we also orient the students to the simulation lab and equipments. Every semester we do that depending upon because there may be upgradation in the lab. So every semester the students are oriented to the simulation lab and the equipment in the lab. And we conduct mock OSCE with feedback sessions to the students. As I already told, mock OSCE is conducted. Then during the examination, before the examination day, we do OSCE preparatory meeting with the students. Also, we do OSCE preparatory meeting with the examiners, so that the students are also oriented to the exam and the examiners are also oriented to the exam. Then we do a pre-testing of OSCE with the examiners to make sure that if there are any mistakes, we will correct it, and finally, we will take a printout. So without pre-testing, we will not take a final printout of the scenarios. Then we decide about the time management with OSCE schedule, and we prepare the standardized patient, and there will be an OSCE coordinator coordinate all the OSCE schedule. And we also get permission from the students to record the OSCE sessions, because since I'm in an Islamic country, some students may not be willing to record the session. However, we explain to them this is for their good, because in case if they go wrong, we wanted to rectify that. So we get permission. We ask them to sign in the record permission sheet. Then they sign it, and we also get a confidentiality pledge signed, so that the students will not miss out any of these during our OSCE preparation. So this is our, if you see our institution, we have student learning outcomes. Based on the student learning outcomes only, we have created the OSCE scenarios. So for example, our main objective is, upon completion of Bachelor of Science in Nursing, the graduates are expected to provide ethical and professional nursing care, ensure safety and quality in the care, utilize evidence-based nursing process, provide leadership in the delivery, management, and advancement of healthcare, practice effective communication skills, adopt critical thinking skills, collaborate and work effectively, demonstrate the ability to learn independently. These are the 8 skills. Hello? Yes? Somebody is, can you mute the mic, please? Somebody is talking. Can you mute the mic, please? Okay. So these are the 8 student learning outcomes we have in our university. So in the OSCE station also, if you see, we make sure all these 8 SLOs are evaluated in our students, I would say, because these all 8 SLOs are kept in 3 different stations: direct patient care and patient safety, critical thinking and leadership, and evidence-based practice. So we keep 3 stations in advanced clinical nursing course to evaluate the competency of the students. So if you see this is an example of OSCE prep sheet. Okay. So before the semester itself, we will give this OSCE prep sheet to the students, and the students will have the prep sheet with this checklist of skills, and the lab will be readily available to practice all the skills. For example, surgical dressing, IV drug calculation and preparation, adult CPR, reflow check and insulin administration based on sliding scale, nebulization, sterile tracheal suctioning, intramuscular injection and drug calculation, subcutaneous injection, vital signs, calculating the drug dosages, subcutaneous injection, then basic life support, CPR, the safe disposal of sharps, medication administration, peak expiratory flow rate, wound care, urinary catheterization, hand hygiene, palpation, auscultation, newborn check. All these are some examples of OSCE prep sheet. So we will be giving this prep sheet in the beginning of the semester, so that the checklist also is given to the students, so that students will start preparing and practicing these skills in the laboratory. If you see, this is our global rating scale, what we use in our university. This is based on Benner's novice to expert model of description. Okay. So if you see this, poor, fair, satisfactory, good, and very good. These are the rating we are giving for the students. So 0 to 4, because we are following Benner's novice to expert models. Therefore, it is from 0 to 4. So at the end, we will decide whether the student is safe or competent or pass, or the student is unsafe, incompetent, or fail. Based on that, we evaluate the students. So this is the global rating scale description, what we follow in our university. If you see, this is one of the evaluation scale. Say, for example, I told this is a scale for evaluating direct patient care and patient safety competency. So why I have marked certain points in red? This is called as critical elements. So why it is called as critical elements? Because in case if the student did not follow this particular step, we will consider the student that failed or unsafe. Why? Because this is a mandatory part of a particular skill. Whereas if a student is missing any particular part of the skill, the student will be considered unsafe. So in other parts, if you see either 0 to, we will give mark from 1 to 4. But when the student is making a mistake or missing any one of this highlighted part, we will put 0. When the student is getting 0 in one component, that means the student is failed in that particular exam. That is the way we do. That is the reason I have highlighted a few things, because we keep 3 critical elements in every OSCE exam. So any one critical element, if it is missed also, the student will be considered failed. And coming to the next one, critical thinking and leadership station. Again, this is another rubric where we have, I have highlighted 3 items. So if the student is missing any item in this particular scenario, the student will be considered unsafe. Why there is a second column like competency specific criteria? This left side, whatever we have mentioned, is a general guideline. However, if I am preparing wound dressing, I will have specific criteria related to wound dressing in this middle column. So the examiners will keep it as a checklist, as well as they maintain the global rating scale, so that they will be able to give the marks according to the criteria specific to the wound dressing and against this criteria, so that they will be able to give the marks. Again, the critical elements are given the highlights, and if they miss, the students will be unsafe. Okay, so that is the way we do for this particular station. And when we consider this, for this direct patient care and patient safety, critical thinking and leadership station, it will be a manned station with standardized patient or mannequin. Usually there will be a standardized patient who will be trained, and each station will run for 20 minutes, and the examiners are evaluating with the global rating scale. On completion of both the stations, feedback is given. Why? Because when we are giving feedback immediately after the station, we found that the students are becoming panicky, because when they know their weakness, when they go to the next station, they are failing automatically in the next station. In order to avoid that, we have decided to give the feedback when they complete both the station. Okay, so this is considered as an exit examination in our university, and there will be always, we used to invite 2 international reviewers from USA because since our university is accredited by ASN, we invite international reviewers from USA. They come, they observe our examinations, and they give feedback on the examination. So based on that only, since last year, 7 years, we have really improved a lot in our OSCE examination, and nowadays it is recommended as a best practice by the ASN, the accrediting body. So that is how we have improved the OSCE practice in our college. So this is the last station we do, evidence-based practice competency station. This is a pen and paper station. Those 2 stations I told you, standardized patient station. This station is a pen and paper station where we wanted to measure whether the student is able to integrate evidence-based practice in the clinical practice. So for this purpose, we always keep this particular thing. This is again for 20 minutes. There will be a clinical scenario given. From the clinical scenario, the student should be able to identify the PICO from the clinical scenario. You know what is PICO? Population, intervention, comparison, outcome. So the student should be able to identify the PICO from the scenario. And we will be giving 4 printed articles, which will be having similar to the particular clinical scenario. However, only one will be answering to the PICO. So the student has to pick up one article which is exactly answering to the PICO, and they should be writing the reference of the article in APA style, and they should write the database from which the article is chosen, and they also should write the level of evidence. Maybe all of you know that level of evidence, the TBP level of evidence, because the top level is the systematic review of randomized control trial. Then next one is randomized control trial. Then quasi-experimental studies. Then like that, we have the level of evidence sheet. With that, the student should understand which level of evidence this article is about. And after that, based on the identified evidence, the student should be identifying the recommendation to use the best available evidence in our hospital. This is how we do for the EBP. So in this station also, it will be a very tricky station where the students, unless and otherwise the students have the EBP knowledge, they will not be able to do this. Therefore, we give training for the EBP station as well. So this is the program schedule we prepare usually before the exam. So on day 1, what we are going to do. On day 2, what we are going to do. You might wonder why there are 2 days or 3 days. Say for example.
Ma'am, can you please repeat EBP station again?
Sure. In EBP station, we usually run the station for 20 minutes. So we will be keeping this. We will be keeping a paper. In the paper, there will be a clinical scenario. So in the clinical scenario, it will be, say for example, I may be wanting to know effectiveness of gangrene mother care on neurophysiological outcomes of preterm newborns. Okay, imagine that this is my clinical question. So in that situation, the student has to identify the PICO. What is the population? Preterm infants. What is the intervention? Gangrene mother care. What is the comparison without any intervention. Then what is the outcome? Neurophysiological mechanism. So student has to identify the PICO from this particular clinical scenario, and the student has to pick up one article, which is because we will be giving 4 articles which are answering to the PICO. Some article may not have the exact PICO, but only one article will be exactly having the PICO. That particular article, the student has to pick up from that particular 4 article, and the student has to write the article reference in the APA style, and they should be writing the database from which, say for example, the database, various databases we can download the article, from which database they have downloaded the article, and they should be writing the level of evidence. There is the EBP level of evidence that we can tell you. I think all of you may be knowing the level of evidence sheets. We keep the level of evidence from top level hierarchy to the lower level hierarchy. Say for example, qualitative studies, opinion, all that will be coming in the lower level, because we cannot consider that as a high level of evidence. Only the randomized control trial of systematic reviews of RCTs comes on the top, then RCTs comes on the second, then experimental studies, quasi-experimental studies, pre-experimental studies, then observational studies. Like that, this level of evidence comes down, narrowed down. Therefore, the student should be able to choose which level of evidence that particular article is speaking about. And based on that, whatever recommendation the particular article is giving, the student should identify this is the best evidence which is identified in this EBP station, and the student should be able to recommend that to our hospital. That is how we evaluate this EBP station. Hope it is clear for all of you.
Yes, ma'am. Thank you.
Okay, fine. Now, this is a program schedule. For example, before the OSCE examination, we prepare a program schedule. Okay. So in this program schedule, we keep for 2-3 days, depending upon the number of students available. Hardly we will be able to examine depending upon the number of examiners, because it takes a lot of efforts. So number of examiners are more, we can finish the exam in 1 or 2 days. If the number of examiners are less, we may have to extend the exam for 4 days even. Therefore, based on the number of students available in the particular semester, we divide the students and into groups. So first day, these many students and these many examination teachers. We call it as mirror station. Mirror station means the same station will be run simultaneously. For example, if there is a direct patient care station, another direct patient care station will be running in the next room. So the team of examiners will be observing the direct patient care. So similarly, in case if I am preparing one scenario for today, the same scenario should not be repeated for the next day. Why? Because the students who have completed the examination may go and share their feedback to the other students. Therefore, if I am preparing one scenario for one day, that scenario should be completed that particular day. After that, I should not be using the same scenario on the next day. I should be having a completely new scenario on the other day. That is the reason it requires a lot of preparation. At least 1 month before the examination, we start preparing for OSCE. So we keep up a separate file itself for OSCE. We keep everything ready separately in different folders. OSCE scenario 1, OSCE scenario 2, EBP scenario 1, EBP scenario 2. We keep lots of scenarios. We brainstorm. We use our mind a lot and in preparing this OSCE. So it's a lot of work, but I really, in the beginning, it was quite challenging for me. After that, I started enjoying doing it. Now I really got a good expertise and I became more familiar with the OSCE sessions. So this is the program schedule. Then this is a panel. So we decide how many students who will be examining. Say, for example, before itself, we will give it to the examiners. These are the students you will be examining on this particular day. These are the students you will be examining on this day. Like this, we will be giving to the examiners beforehand. And this is attendance sheet we maintain. So that particular student's name should be written, as well as we should be getting signature before they enter into the lab. So this attendance sheet we do. And this is a scoring sheet, because there will be 2 examiners, examiner 1, examiner 2. So their scores has to be accumulated and it should be aggregate should be taken. So this is OSCE scoring sheet. Then this is the incident report form. So for example, when the student is unsafe, the student has to sign in this incident report form, because some students will not sign in this because they will keep arguing that I did not do mistake. So in that situation, in order to prevent further complications, we have something recording to convince. So next one is incident report form. Immediately after they finish both the stations, we usually get signature. In case if they are unsafe, we usually get signature in this format. I, the name of the student, registration number, acknowledge that I was stopped from proceeding further with the examination due to the grave error which should have harmed the patient. I further acknowledge that I was explained by my mistake by the examiners. So that the error committed has to be explained by the examiners. The student has to sign witness 1, witness 2, and the course coordinator. All of us have to sign, so that all of us are agreeing that the student is unsafe, so that this will be an evidence that the student is unsafe in that examination. And this is the feedback form. After the examination, we will be getting feedback from the examiners. So they will be writing the commendable aspects of the examination. They will be writing about the areas of improvement in the examination, and they will be writing about the recommendations for further improving the process. So all this we will be getting on completion of the OSCE examination from the examiners. And I wanted to tell you something about unsafe practice criteria, which is very important, because with this unsafe practice criteria only, we decide whether the student is safe or unsafe to practice, okay? Because unsafe practice is defined as any action threatening or jeopardizing the patient's safety, health, or life. So here, when the student can be considered unsafe, in case if the student is not able to identify the patient properly, because usually we do a patient identification with 3 checks. So student has to call this patient by name, and the patient has to respond. The student has to verify the patient ID, and the student has to respond, and the student has to verify the case sheet and call the patient again, because 3 ways we check the patient's ID. So in case if the student is failing to do any one of these steps, the student is considered unsafe. Similarly, lack of knowledge regarding action and effects of medication, that is unsafe situation. Medication administration errors in 9 rights. In case if the student does any mistake in the identification of right patient, right drug, right route, right time, right dose, right documentation, right action, right form, right response. In case if the student is doing any mistakes in this, the student can be considered unsafe. Lack of aseptic technique in all sterile procedures. Say, for example, when they are performing wound care, handling central lines, caring for immunocompromised patients, repeatedly contaminating the invasive lines, avoiding hand washing. When they are doing any of this, they are considered unsafe. And leaving patients unattended, especially unconscious patients, disabled patients, infants, newborn, and patients with suicidal tendencies, if they are leaving them unattended, then they are considered unsafe. And causing environmental hazards that jeopardizes the patient's safety and causing excessive property damage, such as fire, they are unsafe. Failure to communicate significant findings in documentation and reporting about the patient. Say, for example, when they are communicating to the doctor, I gave an example about a clinical situation where the patient blood sugar went up. So when they are communicating to the doctor, they should use SBAR communication. When they are communicating to the doctor, when they are not following the SBAR communication strategy, they may be considered unsafe. And failure to maintain patient confidentiality, unsafe handling of sharps and needles, omission of major scientific steps, negligence endangering patient's life, and not adhering to the hospital policies. All these are the categories they get as unsafe practice. If the student is not doing any of these, the student will be considered unsafe in our OSCE exams. So the final thing is, I just wanted to say how our faculty are helping and the team is helping in this. We call the course team, which is the facilitators. They will be ensuring that the labs are ready for the testing of the students, and the students will not be permitted to enter the lab 3 days prior to the exam, because the student should not know what the scenario is going to be, so that the students will not be permitted to enter the lab 3 days prior to the exam. The examination panel should perform the role of a physician if required. In case if the students are calling, hello doctor, I would like to get orders, the examination panel may have to say, yes, I'm here, what do you want? So that like a examination panel sometimes should act like a physician. So they have to be trained for that. And either SP or a facilitator will voice over in the OSCE station. They have to give voice like a patient. In case if there is a mannequin, the SP or a facilitator will give a voice instead of a patient. All the examination proceedings will be videotaped, and permission for the videotaping will be obtained. And the files of the OSCE for the examiners will have the program schedule, exam panel, scoring sheet, incident report form, OSCE evaluation rubrics, and OSCE feedback form. The OSCE coordinator will get attendance signs from all the students. And in our OSCE exams, we never allow prompting. Why? Because prompting is not permitted. When we prompt, we are going in a wrong direction. Therefore, no prompting is allowed. The student has to perform however she is performing, and she has to come out. No prompting is allowed during the examination. And during the examination, we will not stop the student from progressing in the OSCE station because it is a dummy or it is not hampering the patient. Therefore, in order to prevent the anxiety in the students, we used to inform about the unsafe practice only on completion of both the stations. And after that, in case if the student is unsafe, we will discuss among the examiners, course coordinators, and we will explain the mistake to the student, and we will get signature in the incident report form. And finally, whoever is unsafe, the particular student who is failed in the particular station, the student will remediate in the laboratory for 1 week, and the student will get more training on the particular skill in which the student failed, and the student will repeat the examination after 1 week. This is what we do in our exit examination. This is a sample OSCE scenario. I just kept it for you because what are the student copy we give? I have just taken a screenshot of my papers. This is a description of the case. Okay, name of the student, ID number the student has to write, and we will be giving all the information, which hospital, patient name, MR number, ward, age, doctor's name. So we will write Ahlam, 53-year-old female is admitted for cholecystectomy. She has history of type 2 diabetes mellitus since 10 years. She is non-compliant to the management of diabetes. Today, Ahlam is very anxious and annoyed as her surgery is postponed as her fasting blood sugar is 13 millimole per liter. She also complains of frequent urination, excessive hunger and thirst. You are expected to provide priority nursing care to the patient. See, there is no clue. We are not giving which skill the student has to perform. By looking at that, the student has to decide which skill is priority for my patient. So we do something called as AdPay. This is my document. This is a documentation format. Okay. So this documentation format has AdPay. So this is the best format we follow. AdPay means A for assessment, D for diagnosis, P for problem, I for intervention, and E for evaluation. So the student has to, on completion of the skill, everything, the student has to document everything and give it to us. So this is we call it as case sheet. This is for example, particular condition, we give this to the student also because students should understand what is this fasting blood glucose, or which is normal, for the OGTT, which is normal, HbA1c, what is normal. So this sheet also will be provided for the students. And this is a lab result. We give a lab result to the student so that the student has to pick up what is wrong with the patient. So therefore, say for example, in this particular situation, maybe potassium, we have given potassium as low, because the student has to think the potassium is low, whether I can give insulin, because since the potassium is low, without correcting the potassium level, can I go for administering the insulin? The student has to think twice, because the patient should not go into complication. Therefore, I have to check with the physician what to do. So that way, we give some twist in the blood result, so that the student has to pick up what is wrong in this blood result. And this is a sliding scale. So we give the sliding scale also. Based on the sliding scale, the student should be able to decide what is the blood glucose now. Now the patient's blood glucose is from 13. So I should be giving 4 units of insulin. So the student should be able to decide based on the sliding scale. And this is a standardized patient scenario, as I mentioned. So what is the student expected to speak? What the standardized patient is expected to speak? What the doctor is expected to speak? So all this will be written in the dialogue. So this also has to be tested by the SP, as well as it should be practiced by the on-call doctor who is acting in the particular station. So student, whatever the student speak, accordingly the standardized patient will be talking, but not too much talk should be encouraged. We should not encourage too much of talking in this thing. And this is the lab request. Usually we send it to the laboratory. So we will tell the lab faculty to keep all this ready, so that they will keep all this ready with this, because it's a lot of work really. With all this, we need to prepare and send it for each station. So this is a lab request. And this is a Glasgow Coma Scale, just for reference, in case if the student wants to understand the Glasgow Coma Scale of the particular patient, we keep that also. So I am just telling you, whatever is related to the patient condition, everything should be made available in the laboratory. So this is our physician order sheet. So doctor may advise insulin act rapid as per the sliding scale. So this is the order. We will be keeping the order. As soon as after calling the order, we will keep this order in the station. The student has to proceed for the skill. And this is again the student, when the student understand that the potassium level is low, the student will call the doctor and ask, doctor, potassium level is low, what shall I do? Then doctor will say, the pot clot, you give 15 mg stat, then you can administer insulin. So that way, this is a punch order. So with this punch order, after that, we keep this punch order. We have to really work in such a way that everything is going in a proper time, so that the time will not be missed. So we keep the punch order. We just introduce the punch order at the point of time. So that way we do it. And our doctor's number also will be given there. So doctor number will be given, and there will be a phone cut. The student has to call particular doctor and speak. So for this also we keep this. All these documents we keep in the lab to make sure that the exam is running smoothly. And the final part of my presentation is benefits of OSCE over traditional clinical examination. This I have really taken based on the research evidences, because I always believe in EBP, evidence-based, because without true research finding, there is nothing to talk. So all this information is based on evidences. So it is identified that OSCE is an objective, fair, valid and reliable examination, and it has validity and objectivity. And we can test wide range of skills and competencies in a single examination, and it helps to reduce the bias. And the skill scores evaluated by OSCE were significantly better than that of OSCE scores. TCE scores. And OSCE has fair assessment tools. OSCE has clear instructions. It minimizes the chances of failure, and it highlights the areas of students' weakness so students can correct themselves. And it's a true measure of clinical skill, And because of the personality and social relations of the examiners will not affect the students. Why? Because it is very objective. The examiners cannot have any subjectivity in the evaluation. In case during the clinical examination, the examiners who may not like the student may have some influence on the results. But in the OSCE, it cannot happen because there is a two examiners. We see the inter-rater reliability, so that there is no chance for influence of the examiners on the exam. Then OSCE ensures consistency across all the candidates, and similar skills and questions are done for all the students. And it is very structured and organized examination format which goes on a logical sequence. And because of the structure and because of the expectation to perform various procedures, it has improved the learning process of the students, and it helps the learners to reflect on what they've already taught, and they can demonstrate their skills. And it really gives, especially the students who are exposed to OSCE, are satisfied in the areas of approach, instructions, organization, quality, performance, validity, and the physical setup of the examination. All these parts, the students are happy. And the students felt that OSCE provided structure and clarity for the instructions, had sequence of the stations, taught wide range of clinical skills, and the examination enabled the students to realize their areas of strength and weakness. And the students also felt satisfactory with OSCE, and students were favoring OSCE than the traditional clinical examination. And similarly, OSCE was perceived to be a better approach than the traditional clinical examination. And some students reported higher level of test anxiety. Most of the students reported higher levels of test anxiety with traditional clinical examination than the OSCE, because since they are dealing with a human being, they had more anxiety than the OSCE. And therefore, OSCE can be kept as a gold standard for evaluating the clinical performance. And TCE is not encouraging them to engage in active learning, and it is not fair and accurate. And the students were less satisfied with TCE than the OSCE. And some students felt OSCE is a little stressful. However, that the reason is inadequacy of time, because I told there may be 5 minutes, 10 minutes, 20 minutes, depending upon the skill. We keep the timing very limited. Because of the time, the students used to be more stressful in OSCE. That is quite natural. And the faculty members felt that the students' achievements were better in OSCE. It saves time, prepares competent students, improves students' performance, enhances the competency, and it is objective and reliable. And also the faculty felt that OSCE provided the true measure of students' clinical skills. OSCE was a fair system of evaluation. OSCE format highlighted the students' areas of weakness, and the environment motivated the students to learn. And the examination atmosphere was calm, and OSCE was also well organized. And only few faculty felt OSCE needed more time for each station. And OSCE was intimidating and frightening because it is so structured and time limited. So it is little frightening and intimidating. Exam was very stressful. The preparation it requires a lot of resources and resources for the OSCE examination than the traditional clinical examination. These were little negative feedback given by the OSCE. However, the positive feedback is very high among the students and the faculty. So the TCE also, it's narrow the range of skills, and in a particular clinical situation, the skills are very limited, and especially we go with only patient history and physical examination and some skills. And most of the things are unreliable, and it is the variability between one examiner and another examiner, as well as variability between one patient and another patient. It makes it very difficult to evaluate appropriately in the traditional clinical examination. Finally, to conclude, I would like to say the advantages and disadvantages of OSCE. Advantages are uniform scenarios for all the students, availability of various skills, deeper approach to learning and encourage more meaningful learning and reflection, safety, no danger or injury to the patients, no risk of litigation, because nobody is going to complain against you because it is a standardized patient as well as mannequin. And feedback we can get from the simulators, and we can the students have a chance to recall, and stations can be tailored to the level of the skills, and it allows for teaching audit, and it allows for demonstration of emergency skills, and they can reflect on the problem solving abilities, and the students can gain more confidence. Coming to the disadvantages, it requires lots of training. As I already mentioned, since I undergone training, having an expert from abroad, I am able to talk to you now, because the training is a lot required. Then the textbook scenarios may not be always same, so we may have to brainstorm more, and we have to develop the scenarios, and it is very expensive. The cost is high, the manpower is required, resources required, time is required, more number of examiners are required, patients or standardized patients are required, more space for examination is required, and it is challenging to ensure that the assessment process is valid and reliable. Unless and otherwise we test it, pre-test it properly. We have to question the reliability and validity of the examination, because everything has to go perfectly, so that when it is perfectly done, definitely it is reliable and valid. In case if there is a problem with the SP, or if there is a problem with the examiner, or if there is a problem with the checklist itself, the validity and reliability of the exam may go wrong. So it is stressful. OSCE can become exhausting for the faculty, especially now. The way I am explaining may be looking simple for you, but the amount of work we do is lot, really. So it is really exhausting for the staff. However, we get a satisfaction that we are doing a good examination. And it requires an extensive amount of organizing, and it may discourage the students from looking at the patient as a whole, because in case if there is no follow-up station, the student may consider it as an independent entity. They may not consider the patient as a holistic patient. That may be one challenge. And last, students only examine a number of different patients in isolation at each station instead of comprehensively examining a single patient. To conclude, I would like to say the introduction of OSCE in use of high-stakes assessment both in undergraduate and postgraduate level is a great service to the scholarship and education measurement. Therefore, I would highly recommend each and every one of you who are attending this session to please introduce OSCE in your colleges and make it as a best practice, and you will get an objective evaluation of your students. With this, I would like to conclude my presentation. If you have any doubts, I'm happy to answer your questions. And once again, I thank the organizers for inviting me for this international webinar. Thank you very much.
Thank you, ma'am.
Very good afternoon, ma'am. My question is, what are the ethical approval for OSCE?
I didn't get you. Can you repeat the question, please?
Yes, ma'am. What are the ethical approval for OSCE?
Ethical approval, I didn't get you, because we are not going to, what to say, it is not a research, isn't it, for getting an ethical approval. It is an examination. We have to plan it in a way that, however, what I mentioned, the same way we have to plan it. There is no need for ethical approval, because only the standardized patient should be trained in such a way that we are not going to harm the standardized patient. For example, if there is an injection, okay, in case if there is some injection to be performed, I will be keeping a standardized patient, and I will be keeping a pad, injection pad. So in that injection pad, the student will be giving injection. The patient will not be harmed. The standardized patient will not be harmed. Ethically, we are not harming anybody in OSCE. There is no reason for getting an ethical approval, or there is no ethical issues in conducting OSCE. Hope I answered your question, Akanska.
Yes, ma'am. Yes, ma'am.
Okay.
Thank you so much, ma'am.
Thank you. Any other doubts? I'll be happy to clarify.
Yes, ma'am. Thank you, ma'am.
Ma'am, I had a doubt.
Yes, Sushmi.
I'm so happy to meet you, ma'am. I'm from Coimbatore.
Okay.
Now I'm an MSc student.
Okay.
I'm the first batch in BSc to participate in OSCE.
Okay.
And then now I'm recalling my experience after going through this. I have worked as a staff for 1 year. That time I was really scared what to do, how to plan for OSCE. I don't know. On the pandemic time, they have closed the colleges also.
Okay.
Okay, ma'am. Now I have a doubt, ma'am. Comparing to MSc, whether we have the same procedure like BSc or any changes?
Yes, we have a lot of changes, my dear, especially when we come for the master's level. I think it is the echoing. My voice is echoing, isn't it?
No, ma'am, it's correct. I can hear you.
Okay. So actually, the difference between the master's and undergraduate skill is, in a master's level, we assess the advanced practice skills.
Yes,
Say, for
ma'am.
example, now I am teaching a course called as health promotion. Okay.
Yes, ma'am.
In
Okay,
health promotion, we are having an assignment of an extended objective. The objective will be very high and it will be extended. Say, for example, when I am evaluating a master student, I will be evaluating from a broader perspective, not in a smaller session. I will do a longer session. Say, for example, I mentioned about 40 minutes to 1 hour. So I may keep the session for 40 minutes to 1 hour, and I may have a comprehensive patient scenario.
Okay, okay.
Yeah, because
Okay.
my voice is audible. So when I give a comprehensive scenario, the student will be expected to move from a station to station until she completes the whole summary. Say, for example, evaluation. So
Okay.
we will be making it more complex and more comprehensive. Is that clear? Did I clarify your doubt, Sushmi? I think Sushmi, did I answer your question?
Yes, ma'am. Yes, ma'am. I got it. I got it. I put
Okay.
on mute unknowingly. Ma'am, can I get your email ID?
Yes, it is judy@sku.edu.om.
Okay, ma'am. Thank you. Thank you so much, ma'am. I'm very happy for you. Thank
Thank
you.
you. Thank you. Any other doubts from anybody?
I have one doubt.
Yes, dear. Who is that?
Good afternoon, ma'am.
Yes, Sundari.
Madam, I would like to ask, like,
Good afternoon, ma'am. Mosmi speaking.
Okay.
Ma'am, very nice presentation. I would like to ask, ma'am, whether for all the procedures we should have a standardized OSCE questionnaire or OSCE checklist, or we
Yes,
can make
compulsory.
it at our institutional level.
No, we should have we should make it standardized. Say, for example, if you want it now in our institution, since we made OSCE as a standardized examination, we standardized all our checklist as a standardized one because we have a standard textbooks, we follow that. And also we consult the hospital because, you know, some textbooks will be giving some set of skills. Similarly, however, the hospital may have little differences in the practice because our students are going to practice in our hospital. So whatever steps we have in the textbook, we should be counter-checked with the hospital practice. So that we should be formulating a checklist which is in consistence with the hospital practice. So that the students will not be misleaded in the practice. When they go to the hospital also, they will do the same thing without making any mistake. Therefore, I would recommend you to standardize the checklist in consultation with the standard textbook and with your hospital policy, so that you go hand in hand with the hospital as well as with the textbook what you're following standard, because we follow Potter and Perry and we follow the hospital checklist also. So we combine it together and we made a standardized checkoff. Is that clear, Musami?
Mosmi, yes, yes, ma'am, absolutely clear. Thank you so much.
Okay, thank you. Anybody else? Any other questions?
Ma'am, good afternoon, ma'am.
Good afternoon, Pratibha.
Ma'am.
Yes, Pratibha.
Yes, ma'am. As you said that Gibbs reflective cycle is used for, whether it is used for overall stations or one station, ma'am.
Each station we should do that Gibbs cycle. Why? Because each station is independent, no? Because each station will have independent situation, and each station, in case if the student is failing or passing in that particular station, each station the student has to reflect on her practice so that she will know where she went wrong. Did I answer your question, Pradeepa?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Okay, thank you. Anybody else?
Hello, ma'am. I am Shashi
Yes.
Rekha, ma'am.
Yes, Sasi.
Yeah, ma'am. I'm happy to hear the presentation, and your presentation was so detailed, ma'am. I'm also from Coimbatore only, ma'am.
Okay.
Yeah. Yeah, ma'am. Ma'am, in our Tamil Nadu MGR Medical University, they are suggesting 10 stations, ma'am. But some institution here we follow 7 stations, and previously we were following only 5 stations. So what you suggest, ma'am? Is it? But whatever it is, we'll give marks for 10 marks only. Okay. So, will be
Station
10.
also.
Yeah, 10. We'll be converting into 10 only.
Okay.
So can you suggest how can it be, and what can you detail about the couplet stations, no?
I didn't get you.
Couplet stations. Here we follow the couplet stations also, ma'am. In the same, yeah, ma'am. Yeah, can you detail about the couplet stations, ma'am?
I didn't get that meaning because in our university we follow mirror station. Are you meaning the mirror station?
Yeah, mirror station. You told like the same scenario. It will be the following the next station.
Yes.
Yeah. Here we couple station in the sense 2 scenarios will keep in a in a level, ma'am. Okay. So then the students will be appearing for the 20 marks like that. So here we follow that couple stations, ma'am.
That is fine. That is fine.
Oh.
Why? Because maybe they
Okay.
wanted to bring it more comprehensively. Say, for example, I told you, there are some independent stations, there are some stations who have follow-up stations, because the
Yeah.
station will have the continuity. Maybe this couplet station also may have maybe like a follow-up station. So they
Okay,
may
ma'am.
be
Oh,
keeping scenarios which are similar, so that the
similar.
students will be able to understand it from a comprehensive perspective. That is the reason they would have kept it as a couplet station.
Couple station. How many stations? How many stations in your university, ma'am? You will.
In our university, it depends. Say, for example, the course I am teaching is Advanced Clinical Nursing course, which is a graduating course.
Okay.
The students who are completing the course, before they exit the program, they have to do. We are doing 3 stations. So in this 3
Okay, ma'am.
stations, you see, first station will be 20 minutes, second station will be 20 minutes, third station will be 20 minutes. Ultimately, 1 hour they will be doing continuously.
Oh, continuously.
Yes,
Yes,
yes.
ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
Here we follow only 15 minutes, ma'am. For each
Okay.
station, we'll give 5 minutes. So
Okay.
5 stations will give 25 minutes per student, ma'am.
Okay. Actually,
Yeah,
it is
in Tamil
nothing
Nadu.
wrong, because even the
Yeah.
literature says we can go from 10 to 25 stations, maximum 25
10
stations
oh,
also we can go. Because in
okay.
College of Medicine, they go up to 25 stations, because doctors, they wanted to evaluate doctors' knowledge and skills from various
Knowledge.
perspectives. Therefore, in College of Medicine, they go with a wide range of skills, but in nursing, maximum up to 10 stations people go up. So not more than that.
Thank you, ma'am. Thank you. Yes, ma'am. Thank you for a
Okay.
patient reply, ma'am.
Thank
Thank you.
you.
Mm.
Any
Yes.
other doubt? I'll be happy to clarify.
Hello.
Yes, please.
Ma'am, this is Menaka SP
Okay.
from Chennai, ma'am.
Okay.
Ma'am, I'm having one doubt of that. Duration of ideal time for each student, ma'am, for students.
Ideal student for ideal time for
each student.
say, for example, it depends. Say, actually,
Station 1, for example, station 1.
that is,
In
it can
case
start from 5 to 20 minutes. 5 to 20 minutes for
5 to
undergraduate program. For master program, it can go from 40 to 1 hour. For undergraduate program, the maximum is 5 to 10 minutes. 5 to 20 minutes only can be given, because students may not be able to perform more than that in the undergraduate level.
Okay, ma'am. For PG students, ma'am.
PG students up to 40 minutes to 1 hour also we can give, because they are more matured. They are more advanced. Yes.
Okay.
Yeah,
Okay. Thank you, ma'am.
Thank
Thank
you.
you very much, ma'am.
Thank you. Any other doubts? Any other doubts? So I'll be happy to clarify. Anybody write anything in the chat box? Princey, anybody has written anything in the chat box? If I missed anything.
Hello.
Good afternoon, ma'am. This is Blessy.
Yes, please.
Ma'am, I just wanted to ask one question. Like, this is for objective structured clinical examination. So, how many mocks we have to give before this examination?
No, it depends. See, so if, say for example, in our university, in our college, we have 5 evaluation criteria. Okay, in that we have ongoing clinical performance evaluation. We give 25%, and we give clinical written examination 30%. For OSCE, we give 30%. Say for example, 12.5% for one station, 12.5% for another station, and 5% for EBP station. So we give 30% for OSCE station. It depends upon the college policy. Say, for example, we are keeping it as a final examination. For final examination, we are giving a weightage of 30%. So it is based on the university requirement, college requirement, because in our university, we have a criteria. It should be 60-40 or it should be 40-60. So the ongoing pattern can be 60, the final can be 40. So we have kept this 30% for OSCE, as well as we have kept 30% for comprehensive clinical written examination. So we are keeping 60 at the end as a final evaluation, and 40 we are keeping for ongoing. So it depends upon the university in which you are working, and the university may have their criteria. In our university, this 60-40% is acceptable.
Okay. Thank you, ma'am. It was a very excellent presentation.
Thank you so much. Thank you so much. Anybody else? If you share PPT, it will be useful for those who are in meeting. Kindly, okay. I think everybody is asking the slides. Maybe I can share the slides, Madam Surbi. Maybe you can give it to the participants, whomever wish to have it. Please share the PPT. Okay.
Yes, ma'am, we need, ma'am. So it will be a guide for us in our institute also, ma'am.
Yeah, definitely. I can definitely share it. So somebody is asking, good afternoon, ma'am. Can we have our own teacher as SPs in the Samsana? Yes, definitely we can have. Because sometimes, SP cannot be paid. Say, for example, now we are paying 1,000 rupees per 1 hour. So similarly, every institution may not pay that much. So in that situation, you can train your faculty to be a standardized patient. Faculty themselves can act as a standardized patient, but only thing, faculty should not give any clue to the students. If they give any clue, then the students may be misled. Therefore, we should not give any clue for the students. Any other doubts? If anybody has any doubts, I'll be happy to clarify.
Hello, good afternoon.
Yes, please.
Sorry, keep carry on.
Yes, please.
Question. How CBT is effective for OSCE?
Can you repeat the question, please?
How CBT is effective for OSCE?
How?
CBT, cognitive behavior therapy, is effective for
Cognitive
OSCE.
behavior therapy. But cognitive behavior therapy, I do not know whether, because it is a psychiatric related intervention, whether it is exactly whether it is possible for you to create such a situation. If it is, if you can create a situation with that, if the students are able to participate in that, and if you are able to evaluate, it is possible, because we can have a rating scale for everything, global rating scale or a checkoff for everything, and you can do it. However, it is depending upon the facilities available in your institution. Since we have facilities available, we are keeping this for all the courses. But depends upon the facilities available, you can create whichever type you can create. But only thing, you have the possibility, or you have the situation to create such a scenario, so that you can do whatever it is possible in the lab setting. Because even for psychiatry, we do have OSCE in our laboratory. Psychiatry faculty used to conduct OSCE for our students. Okay. Hope I cleared your doubt.
Ma'am,
Yes,
Thank you,
Pratibha.
ma'am.
ma'am, in OSCE, manned stations and unmanned stations, no, ma'am. And compared to that traditional methods, shall we use the same components in traditional method?
My dear, traditional method, the problem is you will not get same skill for all the students. Say, for example, if there are 50 students in your class, imagine that, is it possible to get a surgical dressing on the same day for all the 50 students? It is impossible. Similarly, the patient also will be reacting differently to the situation. So the uniformity cannot be maintained in clinical examination, because I was also like you people, I used to think, oh, clinical examination is the best and nothing can replace clinical examination. When I started realizing that the benefit of OSCE, nowadays I fight with my people. Please stop this clinical examination, because it has lot of requirement for resources, and we don't get the same kind of patients, and we don't get the same kind of skills, and the clinical situations will be different. We will not get the proper resources. Everything will be different. We cannot mimic OSCE in the clinical situation, my dear. Very difficult. Hope it is clear.
Yes, ma'am.
Okay. Somebody has doubt. Thank you, ma'am, for send your PPT. Okay. We will definitely share the PPT. What is the difference between OSCE and OSPE? Yes, I already mentioned difference between OSCE and OSPE. OSPE is mainly done in physiology, anatomy, biochemistry, where practically when the students are performing some kind of some kind of spotting, or some kind of testing, when they do it, it can be just observed as a skill. So it is mainly done in those courses, physiology, biochemistry, anatomy, such courses. But OSCE is more organized, where we have a set of global criteria or set of checklists with which we follow with the human values. With the humans, as such, patients are there in the situation to act as a patient, and we will have a more realistic situation in OSCE than in OSPE. In OSPE, it is more with the chemicals and more with the spotting, things like that. That is the major difference between OSCE and OSPE. Hope I answered your question. Somebody asked Binsi. I hope I answered your question. And some other doubts? Anybody else have doubt? Okay, everybody is asking for the PPT only. Okay, definitely. I will share the PPT, definitely. So organizers, please share the PPT, because they have sent the mail ID. I may not be able to communicate to them directly because it is all in the chat. Please ensure that you are sharing the PPT. I already shared with you. It is in your mail. Should be madam's mail. I have already shared. So that, madam, you can share with the candidates. Anybody has any doubts? I'm happy to answer. Fine. Okay. Thank you very much. It was very happy, like I feel so happy answering to everyone. Because,
Thank you, ma'am. It was a wonderful session, ma'am.
thank you so much. I too feel so happy because, I feel that I'm able to interact with everybody one-to-one, and I'm able to share my expertise with you all. Thank you so much.
Thank you, ma'am.
Thank you.
So
Okay.
now, if no question, now house is closed. So today, madam had taken very informative session by using lots of examples. She discussed overview, evidence, designing, preparing for an OSCE examination, the OSCE environment, student preparation, structure OSCE format, gives reflective cycle, marking and scoring, practice guidelines, developing OSCE scenarios, students learning outcomes, stations, OSCE skills preparation sheet, program schedule, OSCE panel, OSCE attendance sheet, OSCE scoring sheet, OSCE examination feedback, unsafe practice criteria, standardized patient dialogue sheet, lab request, physician order sheet, benefits of OSCE, advantages and disadvantages of OSCE. Once again, thank you, madam, for giving us your valuable time with us and clearing our more query regarding OSCE.
Thank
In
you.
today's FDP program, more than 250 participants have participated from different nursing colleges from different areas of the world. Dubai, Canada, Maharashtra, Nagpur, Chennai, Jammu Kashmir, Karnataka. Principals, professors, lecturers, PhD scholars have taken part in today's FDP. So hope this webinar will be benefited for all the participants. Thankfulness is the beginning of gratitude. Gratitude makes sense of our past, bring peace of today, and creates a vision for tomorrow. So I invite Mrs. Princy Shaji, Vice Principal of Jinsar, to deliver vote of thanks.
Thank you, Surbhi ma'am. Pleasant good afternoon to all. It has been such an honor to be a part of this wonderful webinar. On behalf of the Jinsar organization, I, Mrs. Princy Shaji, Vice Principal, would like to extend my heartfelt gratitude to our esteemed guest speaker, Dr. Judy Erlappan ma'am. Thank you, ma'am, for your precious time for imparting your knowledge unto us. It was indeed an illuminating section for all of us. Thank you so much, ma'am. I would also like to thank our patron, Mrs. Sunena Pateria ma'am, for the perfect support and guidance. I would also like to take this opportunity to thank our principal, Dr. Professor Sapna Das, for embrace cooperation in the organization of this event. I also thank our moderator, Mrs. Surbhi Kari, for the conduction of webinar in the successful manner. I want to thank our program coordinator, Mrs. Sarika Ratish, our advisory committee, Dr. Anup Tiwari, Dr. Vinita Suresh ma'am, our organizing committee, Mrs. Aradhna Dhanyavad, Mrs. Sangeeta Pillai, also our technical assistants, Mrs. Shilpa, Ms. Shalini, and Mr. K.C. Rajat. Thank you so much for your valuable contribution, guidance, and encouragement in all our efforts. I owe special gratitude to our non-teaching staff who have worked hard to ensure that this occasion become a memorable success. I thank all the participants who took part. I hope this webinar was valuable and productive for all of you. Once again, thank you, thank you, thank you for your attention. Thank you so much. Thank you so much, ma'am.
Thank you, everybody, again.
Thank you. Once again, I would like to thank our resource person, Dr. Judy Aruplam madam, and all the participants for giving their valuable time and making this event success. Hope this webinar will be very knowledgeable for all of you. After filling feedback form, e-certificate will be sent to your mail. This matter also available in YouTube. Thank you all.
Thank you.